Thank you for those kind words, Honorable Chairman, all the dignitaries, and dear friends. I'm a cardiologist in London, but I'm in very close touch back home here in India, and I at least visit 5 to 6 times in a year. My job is to first stress the importance of Indian population as probably the sickest and the most ill population in the world as far as cardiovascular disease is concerned. And I'll back up my statement by some important data. If I look at London only, and if you look on the left of your screen, is central London, and it's like a metro in Delhi. If you start from Westminster and start going towards east of London, what you clearly see that traveling from east from Westminster, each tube stop, that is metro stop, represents nearly 1 year of life expectancy lost. And the reason being that as you move from Westminster to the east of London, the population of Indian subcontinent people goes on increasing. That tells a story in London itself. If you look at the myocardial infarction and stroke in India, more than 2/3 of infarcts and half of CVA cases are younger than 55 years of age. 25% of all MIs are younger than 40. 70% of cases of MI and CVA have diabetes and hypertension. And MI is 6 times more likely to happen in diabetics. So it simply means that hypertension and diabetes are the 2 most important preventable risk factors for MI and CVA. If I compare the Indian population with population in US and UK, it becomes very clear that the Indian population is having MI and stroke at a much younger age. This has been recently shown in a very important ongoing study called Pinnacle study, which has been established here by the American College of Cardiology. That's what an artery looks like, where the lumen has been reduced only to a small slit. And the majority of the artery lumen is actually an atheroma, with a lot of gunk inside the atheroma and some hemorrhage as well. That's what looks like a CT scan showing severe cerebral infarction. What happens during a process of myocardial infarction, in a very crude way, is an artery gets blocked completely. And the blood supply to the part of muscle supplied by the artery stops, and you get an MI. That's one of the complications of diabetes, showing hemorrhages and a macular star. That's what happens with hypertension, causing left ventricular failure. That's an aneurysm in the cerebral circulation, just about to burst, causing severe hemorrhage. That's again an hemorrhage in the cerebrum. That's what happens due to long-standing hypertension and diabetes with chronic renal failure, and the kidney becomes very small. What I'm trying to tell you is as we age, the main 2 causes of death or morbidity are change in or damage in your DNA causing cancer or vascular diseases. What I mean by vascular disease is stroke, MI, and kidney failure. If I simply look at my patients who come to hospital with acute coronary syndrome, and if I look at that population 1 year late, what I see is the mortality still remains very high, 14.8%. That's a significant number of people dying, even being treated fully and appropriately according to evidence base. And these deaths are mostly due to sudden death, 50%, and 50% within the first 3 months. So if you are a patient who gets an MI or acute coronary syndrome, the problem doesn't stop there. The problem still continues. This mortality doubles within 1 year of discharge from the hospital. Why does this happen? We can see that the building blocks of this atherosclerosis in the artery is the risk factors. Let's have a look at the impact of risk factors. If we see at the cumulative incidence of all-cause mortality through 1 year after acute coronary syndrome, it becomes very clear that the mortality and morbidity in diabetic patients is much higher as compared to non-diabetics. And that is true for ST elevation MI or non-ST elevation MI. If you look at the cholesterol, and if you look at the total cholesterol on the right side of your screen of 6.7 with an LDL of 4.9, so higher is your LDL, higher is your mortality. But if you look at the middle column with a cholesterol of 5.4, which is the usual cholesterol to have in the society, I'm sorry, this is millimoles per liter because we don't use milligrams in UK, but this 5.4 is an average cholesterol. And if you look at the LDL, 3.5 is again high, but it's lower than the column on the right. So as your cholesterol is lower, your mortality is lower. And this continues to the left of the screen. So lower is the cholesterol, lower is the mortality. But if we change one thing in the most left column by reducing the HDL, we clearly see the mortality actually is as high LDL. And if that patient becomes diabetic, your mortality is much higher. So what I mean to say is the risk factors combine together. Why do people die with diabetes? Number one cause of death in diabetes is ischemic heart disease. And we see it, we'll see in following slides, that the impact on mortality in diabetic patients is almost negligible by treating HbA1c only. The biggest impact on mortality by treating hypertension and cholesterol. This actually is a very important slide which shows if you divide the patients of myocardial infarction into diabetes and non-diabetes, it becomes very clear that people with no diabetes but a previous history of heart attacks, their risk is as high as somebody who is diabetic with no previous heart attacks. That simply means that type 2 diabetics actually are behaving like somebody with previous MI. This is also true that as your blood sugar is high on the higher side at admission with an MI, your mortality is also very high. And I'm talking about in-hospital mortality. So in-hospital mortality is linked to your blood sugar level at the time of admission. So we come back to the crux of the problem. And the problem is modifiable risk factors which increase the risk of myocardial infarction. And this is from a very important paper by Salim Yusuf called Inter-Heart Study. Risk factors tend to cluster together. And we know that the more number of risk factors you have, higher is your mortality, which clearly shows from this slide. And in fact, those with a previous history of coronary or cerebral event have a very high mortality. These are called cardiometabolic risk factors. And in fact, you don't have to have diabetes for that. You can be pre-diabetic and still have the similar kind of risk in collaboration with other risk factors like high cholesterol, smoking, hypertension, and family history. And the center to it, you can see on your slide, is abdominal obesity. So abdominal obesity or adiposity is associated with increased risk of cardio or cerebrovascular accidents or events for both stroke or MI. In fact, if you completely forget about stroke or MI and only look at all-cause mortality, then it becomes very clear that your abdominal obesity is responsible for all-cause mortality as well. The problem is the mortality rate from CVD is disproportionate. What do I mean to say? It's 3 times higher in unskilled workers than professionals. Therefore, more common in deprived areas. This difference has doubled in the last 20 years. It's 50% higher for people from Indian subcontinent than the rest of the population in the world. Intra-heart study also showed the one single factor which is closely related to the first MI is your abdominal girth. So abdominal obesity becomes very important simply because when you have abdominal obesity, you have other risk factors associated with it as well. This slide shows the importance of clustering of risk factors like smoking, dyslipidemia, and hypertension, each with its own degree of risk for an event. But if they combine together, that risk is multiple times. Hypertension, you already know that high is your blood pressure. I'm talking about diastolic blood pressure. High is your mortality. So which blood pressure we think is important? Both systolic and diastolic. But this slide clearly shows that the best blood pressure for a population to have is below 80, or to be liberal, below 85 diastolic. So how common is the blood pressure in the society? Well, in urban India, it's about 30 to 70% of the population has hypertension, which is not detected. In rural India, it's about 10 to 17%. What happens to the blood pressure over the age? As we age, the systolic blood pressure starts rising, creating a gap between systole and diastole. So high is the gap between systole and diastole. High is the mortality in that population. But if you look at the rural population, it becomes very clear that nothing happens to systolic blood pressure. The difference between systole and diastole remains the same. But as soon as that person from the rural area moves to urban area, you start seeing this change. So something which happens from urbanization, which affects the way we or our kidney handles sodium, that our blood pressure starts rising. What is the rule of halves? People with blood pressure, 50% are not diagnosed, 50% diagnosed are not treated, those who are treated, 50% are not well controlled, and those controlled, about 12.5% are only on target. And this shows how the blood pressure medication or our lifestyle or a combination of this is ineffective in controlling the blood pressure. This was the first trial which clearly showed that a combination of ACE inhibitor and a calcium channel blocker is much better as compared to the beta blocker. And that's why almost in the West, beta blocker is not being used now for treatment of blood pressure unless that patient has a previous history of myocardial infarction. This is what I meant to say, that if you're young, then you're treated with ACE inhibitor or angiotensin receptor blocker. If you're old, then calcium channel blocker and diuretic. It's a rule of A, B, C, and D, and a combination of these together. We talk about lifestyle problems, but if we look at any population, about 16.8 or 17% of population has prediabetes already. In addition to that, there are about 10 to 12% diabetics who are never diagnosed. So that means we already have a substrate there of 17% people in any population which has a risk for developing diabetes. This is a very important slide from UKPDS trial, which for the first time showed that by intensive blood glucose control for type 2 diabetics, and I mean to say blood glucose control means HbA1c, because if you go to a doctor for treatment of diabetes, what is being hammered is your blood sugar should be controlled. But what's the outcome of that on mortality? Almost nothing. Yes, on microvascular complications, there is outcome data for that. But if you want to impact or you want to have an impact on mortality, there's the blood pressure control for type 2 diabetics, which is more important, as shown in the lower panel. Even if you look at the people who are not diabetic, but if you look at their blood sugar level, even within normal levels, you can clearly see that higher is the level of blood sugar within normal limits, higher is your mortality. That simply means, if you look at the first slide, hypertension and diabetes together is a bad news called double jeopardy. If I talk about what's the basic reason we get a myocardial infarction or stroke or problems in the kidney, these are all big blood vessel related diseases. And the basic foundation of that is an inflammatory process. We know that atherosclerosis is an inflammatory process. In year 1998, I did a very scientific study looking at the inflammation, endothelial function, and infection. My theory was this inflammation and endothelial dysfunction is being driven by infection. And I looked at a theory called dirty chicken hypothesis. If you look at the poultry farmer, what the poultry farmer does is routinely gives antibiotic injections to the chicken. That's why they grow bigger in size. If you kill the chicken who have not been given the antibiotic, you clearly see in the aorta of that chicken a process called atherosclerosis. If you look at the aorta of the chicken who have grown bigger, their aorta does not show atherosclerosis. So there is something to do with anti-inflammatory effect of antibiotic. We don't know about that. But we looked at patients with myocardial infarction. We divided them into 3 on the basis of antibodies to chlamydia, pneumonia, which is very common. And then we looked at the endothelial function both biochemically and by non-invasive method, treated them 6 weeks with azithromycin, and did the whole thing again. And we clearly could show that those people who were given antibiotics, in them the endothelial function improved, to show that inflammation is the basic cause of a continuous process of atherosclerosis. Now, how do we disinflame the artery? That has been a holy grail and has not been cracked as yet. Some people think HDL may be an answer to it. Some people think that an indigenous medicine may be. For example, for malaria, you must know that recently a Nobel Prize was awarded for the discovery of artemisinin in China. We think that turmeric may have something to do with it, or an active ingredient in turmeric can block this inflammatory process, which is driven through activated macrophages in the plaque, causing more superoxide production, causing damage to the lipids or lipid membranes in the plaque, causing lipid peroxidation levels of isoprostanes. And the ingredient in turmeric may be able to block this process at a very fundamental level. So what I mean to say is we know that end organs like brain, heart, and kidney are being attacked by a combination of risk factors, which may be lifestyle related. We know that they are preventable, but we have not been able to prevent them by changing the lifestyles. So can we, or do we have an agent which can protect these end organs in the presence of risk factors from an event? And that may be hidden in turmeric. Thank you very much.